All right, well, welcome everyone to another edition of the IOCDF Research Roundtable. I'm John Abramowitz, and unfortunately, my buddy Kyle, who usually runs the show, Kyle is under the weather, and so he's not going to be joining us today, but that's okay. We're going to do our best to soldier on. I have two of my friends with me, Dr. Evelyn Stewart and Stephen Poskar, and we'll get to them in just a second. I just want to very quickly go over some kind of general announcements before we get too far into things. By the way, our topic today is going to be all about medication for OCD. We'll talk about kind of the first line SSRIs. We'll talk about other approaches to medication treatment. So welcome. I'm glad that you've joined us. And I just want to say that, so in kind of kicking things off, this live stream is educational, and it's not intended to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can also use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. And the International OCD Foundation is not a crisis hotline. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911 or the 988 Suicide and Crisis Lifeline. And you can also access that online at www.988lifeline.org. And we want to create a kind and respectful environment for everyone here. So, at the end of the day, of course, we're all here to support one another. So just a note that, this is being broadcast today and it will live on YouTube in perpetuity. And so just note that, what you are writing in is going to be out there, just like with other social media platforms, and it's being recorded. So with that, just a quick, well, I'll tell you what, let's start with our wonderful guests. So Evelyn, go ahead, tell us a little bit about yourself and yeah.
Sure. Hi, happy to be here. Thanks again. I think I've been on one of these a while back, different topic, but really happy to be here. So I'm a professor of psychiatry. I'm in Vancouver, Canada, which is the country up north of you guys. I'm trained as a child and adolescent psychiatrist, but also work with adults at times. And I do research as well, but I think one of my main areas of interest is looking at improving outcomes for people living with OCD. So happy to be here.
Awesome. Glad you're here. Steve, take it away.
Hi, so I'm Steve Poskar. I am a psychiatrist in New York City, and I specialize in OCD and related disorders. And so, most of my job is treating most people that have usually been to one or more providers, have been on multiple medicines, and kind of aren't getting the results they want for their OCD, or things like body dysmorphic disorder, trichotillomania, and coming to see me and trying to find pharmacological strategies to kind of help them, do better. And again, especially a lot of, what we do when we're prescribing is really trying to help with medication to lower symptoms enough to really do therapy, which is kind of the real mainstay of the treatment in a lot of ways. And so, again, a lot of what I'm doing is kind of bringing down the volume a little bit so people can finally engage in therapy, sometimes maybe where they couldn't before because it was just too overwhelming for them.
Very cool. And I'm John Abramowitz, and I'm a clinical psychologist and professor at the University of North Carolina. Do research on all sorts of aspects of OCD, understanding how it works, understanding treatments. So I enjoy monthly helping to host with Kyle. Kyle is a lot more, what's the word I'm looking for? He's, I don't know, he has the Kavorka, and I'm not as charismatic as he is. So I hope folks will stick with us today. That's always my anxiety kind of going into this. I should say that we are monitoring your comments, folks out there who are tuning in. So please feel free to ask us questions and give us comments and things like that. And we will monitor that. Okay, so for starters, it might be good to kind of give folks an idea. people know, I think, the names of these medications, and we see them on, commercials, and we read about them and stuff like that. But what is an SSRI, and how does it work? I'll throw that out there. Either of you, take it away.
Okay, sure. So an SSRI, actually, the thing that is proven to help most in OCD is called an SRI. So that's a serotonin reuptake inhibitor. The SSRIs are a group of meds that are under that umbrella. They're selective serotonin reuptake inhibitors. So how they act in the brain is effectively, it acts mainly on the serotonin reuptake transporter. So it acts in the synapse, the connection between brain cells. So how the brain works is there's a communication across the brain that happens between neurons. I'll use my hands as neurons. So this would be one neuron where there's a signal that's sent down and then it's stimulated to release chemicals. So when we're talking about SSRIs, it would release serotonin in this gap between the neurons, and then it would act on this next to continue that signal along. So with OCD, to oversimplify, there seems to be difficulty in terms of serotonin. So the serotonin reuptake inhibitor, how it works is usually, the serotonin is released, and the serotonin that's in here, the level doesn't seem to be high enough. Again, this is oversimplifying. So the reuptake inhibitor blocks this vacuum cleaner from sucking up the leftover serotonin. More serotonin is here to be left to activate to continue the signal along. So that's a gross oversimplification, but effectively that's how it works. And there's downstream effects. In OCD, it seems to be blocking that reuptake of the vacuum cleaner back in to that initial neuron. That seems to be helpful. You can tell I'm a child psychiatrist. I use signals, but Steve, you might want to expand on that a bit more scientifically.
No, I think again, I'm going to start using the hand model. So no, I think that was really well explained, and so like Dr. Stewart said, basically the drugs that we use are serotonin reuptake inhibitors, and SSRIs, which are selective serotonin reuptake inhibitors, and we use the word selective because at the time we thought mostly what they do is block serotonin reuptake and not much else. We've kind of learned that's not as true as we maybe thought it once was, and SSRIs, different ones, can affect other neurotransmitters. And again, the first medicine we really ever used for OCD was a medicine called clomipramine, or anafranil. And that was an older drug called a tricyclic antidepressant. And there were other tricyclic antidepressants, and they didn't really do anything for OCD. And so the question was really, well, what's different about clomipramine? And the main difference of clomipramine was, as opposed to the other drugs, which really blocked the reuptake of a chemical called norepinephrine or noradrenaline, clomipramine really did a lot more blockade of the reuptake of serotonin. And then when kind of SSRIs came out, we kind of said, well, they also block the reuptake of serotonin. Maybe they'll also work for OCD. And lo and behold, they did. And those drugs include things like Prozac or fluoxetine, Luvox or fluvoxamine, Zoloft or sertraline, Lexapro, which is escitalopram, Celexa, which is citalopram, and Paxil, which is paroxetine. And all of those SSRIs appear to work for OCD. The only real difference is when we use kind of SSRIs for OCD compared to when we use them for things like depression or anxiety disorders. Often it seems that higher dosages are required than what's typically used. we've kind of started to use the SSRIs a lot more than clomipramine, not because they work any better, but because kind of clomipramine does have a handful of side effects that makes it a little bit more challenging. And depending on which studies you read, there were some head-to-head studies that showed that they were all about the same SSRIs compared to clomipramine, but then there were some other analyses and large meta-analyses where it looks like clomipramine has a little bit of an edge. So most of us who do this, we often will try one SSRI at a high dose. If it doesn't work, we often try another. If two don't work, it's very common then at the third try to try something like clomipramine. And again, there's no real data or evidence to support that any SSRI works any better than any other SSRI for OCD. For whatever reason, some people respond to one and not the other, and we're not exactly sure why that happens. But all things being equal, there's not a lot of data to support that. There's a little mythology behind drugs like Luvox, that Luvox is somehow this special OCD drug, and that's just not the case. And again, all of them appear to work about the same in a given group of people.
When I was first getting interested in OCD, when I was in graduate school, Steve, you mentioned the research where I guess they were trying. I remember a study coming out, clomipramine against imipramine, right? I guess so, anafranil versus tofranil, and finding that anafranil was better than clomipramine. Right? So drugs have different names, right? So clomipramine is the same thing as anafranil, and tofranil is imipramine. And I remember reading that and really, being interested in, they were just kind of coming up with this serotonin theory, this idea that, okay, it's clomipramine that works best, so there must be something with serotonin. And that takes me back to I remember where I was when I was reading those articles. It was a blast from the past, I guess, that you brought up. You also touched on, there are these there's 5 or so different SSRIs or SRIs that are used for OCD. Why are there so many different ones? What's the difference between them? What can you guys say, for people who might be wondering, how come there are all these different types of SSRIs? Why has that happened in the world?
I mean, I think the pharmaceutical industry.
I was gonna use a hand signal and do this.
Yeah. So I think basically it's different companies after realizing that there is this group of medications, SSRIs, and if you're using that mechanism, it can be quite valuable for OCD, depression, anxiety, lots of different aims. So I think the main thing to keep in mind is when you're talking about OCD, as Steve said, really with the exception of a couple little studies, including a recent network analysis, they all seem to have similar efficacy, meaning ability to work to help the OCD. However, they're different in other ways. So the side effect profiles can be quite different across them. Some may be a bit more sedating and some may be a bit more activating. So sertraline at higher doses, it has more dopaminergic effect. So it can be a bit more activating. And there also seems to be, although this is, we're still learning more about this, but there may be a genetic component of it. So just with the genes that you happen to have, there may be how quickly or slowly you metabolize the medications may differ. So they're broken down in different ways in the liver using different what's called cytochrome P450 systems, but big fancy way of saying how the liver chops up the medication and delivers it to your body. So there's differences in this way that can be quite important. This will be why we would often ask, Steve, or I would often ask, is there anyone in your family who's taken an SSRI before? Anyone with OCD where there's been a certain med that's worked better for them? It doesn't mean that would be better for everyone else in the population, but there's likely to be some genetic component that may influence. And again, it's really early days, so I'm not a big believer in, sending away, giving a bunch of money, getting a report that's going to tell you magically which med is better. That's not the case in OCD right now. but they do differ from each other. And I think one of the important things to know is, so if you're out there, you've done an SSRI trial, you've taken it as prescribed, you've waited a chunk of time. So again, we don't expect a result in 1 or 2 days, like, taking a Tylenol or even at 1 or 2 hours. We have to wait a number of weeks. So I would say at least 6 to 8 weeks. But if you've done that, you've gotten up to a high enough dose, it's not working. That does not mean that none of the SSRIs are going to work for you. Actually, with one of the studies that has been done, there's still like a 40% chance that another SSRI would work for you. And again, even as we start out, something to know about is the response rate for SSRIs is around, it depends what you look at, it's kind of like flipping a coin. So around 50%. And we don't know for a particular individual which med may help. So that's why we'll go to other things like side effect profiles, family history of response, to pick which one of the SSRIs to start with. But if it's not helping, that doesn't mean we throw in the towel. We go to another one. And I would say there's a paper that's just come out to find a way that we can use clomipramine more safely. So actually trying any medication other than fluvoxamine, and then trying fluvoxamine and then adding in a bit of clomipramine is a way that you could more safely try clomipramine, although that's based on a very small study that was just published, but the field kind of knows about this.
Right, and it's a thing we've all been doing. It's one of those things, like in our world, it seems like very common knowledge, but it's really important for people like Dr. Stewart, who recently came out with a paper, to talk about this stuff, because in our little world, we think everybody knows that trick, right? And the reality is people don't. And so it's really important that people like Dr. Stewart are publishing these things, so that people just outside of our bubble, as it were, kind of can know about these things, because it is one of the reasons. I think a lot of what happens, that when we see patients, by the time they get to someone like myself or Dr. Stewart, a lot of the reasons things hasn't worked is people will say, well, I've been on Prozac and I've been on Lexapro. And then you find out, well, I've only been on 40 milligrams of Prozac, or I've only been on 20 milligrams of Lexapro. And so, anytime you're kind of seeing a patient on medicine, you just don't need to know what they were on, right? You need to know what the doses were and for how long. And a lot of times what we find is people think they've been on adequate trials, and they haven't. And then when we finally get them, even on drugs they've been on before, but we push them up higher. And I think a lot of psychiatrists are a little wary of that. They're just not used to pushing up these medicines high. And I can tell you, for people like us, we often go to really super therapeutic doses that a lot of people, so for something like Zoloft, you'll often use like 200 to 300 milligrams for people with OCD. But I have people on 450 milligrams of Zoloft, and who have done really well. And part of that is, I think, like Dr. Stewart mentioned, we have these kind of enzymes that break these things down. And you don't know that there's somebody who at 450 milligrams of Zoloft might end up with the same brain levels as somebody that has 200 milligrams of Zoloft, because they're breaking it down at different rates. So we kind of know everything is a bell curve. And so we know about the general doses people will respond to. But especially if people aren't getting side effects, sometimes, again, we really push them up high, and we find that people can do really well that haven't responded otherwise.
And I'll just jump in and say, but the good news as well with SSRIs is that we have a lot to try. So I guess it depends on your approach to pharmacology. I tend to just sort of jump to another one because we have other ones. But again, the interesting thing is new isn't always better. So clomipramine is this old-fashioned medication. We came into an era, then there's SSRIs, which were the new fancy modern version of serotonin reuptake inhibitors that have a better side effect profile. That's true. But it's just interesting that it seems like that old-fashioned one, clomipramine or anafranil, there may be something a little bit different. But if we figure out a way to make it more tolerable, then that's key. And again, if I can, I know this is supposed to be about medications, but I totally want to echo what Steve said at the beginning. How I see medications, the role of medications in treating OCD is they're a helper for cognitive behavior therapy. Really, if you're wanting to live a life with OCD, it's pushing back exposure response prevention, potentially ACT. But that doesn't mean medications don't have a role, because sometimes the intensity of the OCD is just so strong. It just feels like, how in the heck am I going to do this? I can't even think about doing an exposure right now. So really dampening down the intensity of the OCD, I see as the main role of medications.
And I was going to say, to follow up, I think one easy way to kind of like say that for people is, at the end of the day, there are people that can get better from their OCD with therapy alone. There's a definite group of people that they're able to engage in therapy, and therapy alone works. There is nobody that gets better than in my opinion, on medicine alone for OCD. I think there are some people that improve, but I don't know that anybody gets to the level that I would want them at, in my experience, on medicine alone. And part of that is because even if the medicine is lowering down symptoms, if people still engage in compulsions, you're constantly revving up the OCD. So you're kind of fighting yourself in a lot of ways. And again, I think for a lot of people, the combination is best, but it's very rare to see somebody who you just give them medicine and that alone kind of does the trick.
And I think one of the big things there as well that we found, there's a study lots of years ago now, where it's not just when you're actively doing the treatment, but after you stop. So if you do CBT and then stop, or if you do just meds alone and then stop, the risk of having relapse of your OCD is much higher with meds, but less so with CBT, which makes sense, because if you have the tools, you know what to do, then with CBT, then you know how to fight OCD again. So I think it's like in the follow-up period, it becomes relevant. But really, I think I really don't hesitate much at all about starting meds in someone where they've tried CBT. They may not have access. Their OCD is moderately severe or severe. It's getting in the way of their life. So there's no shame in that at all. And they're proven in children, adolescents, and adults, these SSRIs for treatment of OCD specifically. If I could add one more thing.
Yeah, this is great. You're making my job easier. Go for it.
Okay. Yeah. I can ramble on, so just jump in if I'm going too far. But just thinking of another question that comes up to me, sometimes people will say, well, it's called an antidepressant, and I'm a bit down because I have OCD. So you're giving me this medication so I don't feel badly about having OCD, but it's not going to help my OCD. No, that's not the case. So we know from trials that although they're called antidepressants, that's just a name that they gave this group of meds, it's been proven to specifically help with OCD symptoms themselves, also with anxiety, also with depression. So we're not just using these medications to try and help the background other stuff that might be happening. It's important to know that they've been shown to directly address the OCD obsessions and compulsions.
And I think it's important to lastly add on. So SSRI, so antidepressants, a lot of times drugs get a name for the general population based on the first thing we use them for. So because a lot of SSRIs were first used, they're kind of part of this group of antidepressants. And we have the same thing with other groups. So we have a group of medicines called dopamine blockers. And dopamine blockers or D2 blockers, we commonly call antipsychotics. And so then people get nervous when you try them on someone, they go, well, you think I'm psychotic. And it's just remembering, so like with SSRIs, all of the SSRIs can be used as antidepressants. Not all antidepressants work for OCD, right?
Yes.
The only antidepressants that we know that work for OCD are things that block the serotonin reuptake. And so, it can get really confusing for people that kind of are lay people with all the name confusion. So a big part of our job, really is doing a lot of education with patients. a lot of people, I always tell people, if you don't want to be on meds, that's completely legitimate. But I don't want you to not be on meds for reasons that aren't actually factually true, right? I want you to be educated, and then it's your decision, but I want it to be an educated decision. And a lot of times people will say, well, I don't want my liver to fail. And it's important for me to say, well, SSRIs are not really known to cause liver failure. So if you don't want to be on SSRIs, that's okay. But I want to make sure. And so a lot of what we have to do, and I think that's, the other thing that Evelyn pointed to before is, the other thing is we don't want anybody not to be on SSRIs because they think they're cheating, right? That I'm cheating the therapy. I'm not really, I should be pushing myself harder. I shouldn't need an SSRI. And I think a big thing, one of the things we talk about is, look, this is a brain, and there are multiple ways to affect the way the brain works. And therapy affects the way your brain functions, as do medicine. And it's not cheating, and it's not, and I think that's really important for people because sometimes people don't do it because they feel guilty, or, and for us, a lot of our work is really having those discussions.
And I would say, and it's such a good point, especially with OCD, because there can be a tendency to be overly responsible, or to not want to burden others, or somehow have it in your head, I need to fix this myself, and I can't cheat. So, while it can be tough for anyone to debate, risks and benefits, am I going to take a med? I think particularly for individuals living with OCD, it can be really, really hard. And also to take credit for it. If they've taken a med and then they start to do ERPs and they're able to gain ground, I really try to discourage people from saying, oh, it was just the medication. No, it was you. Okay, maybe the medication made it possible in that moment to be willing to give it a try. But now that you've practiced it, that makes brain changes itself. So that was all you.
I see, it's interesting to say that because I see that all the time. So I do CBT, I don't prescribe medication. And I'll have people that will come in and they'll be like, I've been on medication, for 10 years, whatever. And I started doing the exposure and response prevention, and finally the medication kicked in. Oh no, but you think about, you're changing your behavior. You're doing something completely different. You're doing a new therapy that you haven't tried before. Give yourself some credit for taking action and changing your behavior and your thinking, because that can make a big difference too. We know that it does, as you guys were saying. Yeah. So there was a question that I do want to get to. You guys touched on this a little bit, but I think this is important because another thing that comes up a lot are these ideas. And Amanda, at 12:14, this is LinkedIn user who asked. Amanda's behind the scenes. She's the one that puts the questions up there.
Hi, Amanda.
What? Say again.
I just said hi, Amanda.
Okay, there you go. For those of you who weren't with us before we started, Amanda's there behind the scenes doing her wonderful thing. Are pharmaceutical investigations or tests that clients can undertake to see what would work best prior to trying medications? And I just want to tell a little anecdotal story. Before I came to University of North Carolina, I used to work at the Mayo Clinic in Rochester, Minnesota. And there were some researchers there that were working on developing a test where you would, take a blood sample, and you could use the blood, you put it over, I guess you can kind of see using the blood what types of, genetics, enzymes the person has, to get a sense of whether the medications would work or not. My understanding was it's not so much about are the medications going to work, but it's more about what's your side effect profile. How quickly, and I think it was you, Evelyn, who was saying this before, how quickly will your body break down the medications? How long will they stay in your body and be given a chance to work? But I guess one thing is, how do these tests work? And B, and one of you guys said that you had some doubts about them. So we should talk about that, because I think there are a lot of people spending money on these things that unfortunately are not always going to pan out. So your thoughts about these kinds of genetic tests for medications?
So I think you made some really important points there. So one thing is, one of the things these tests do is they look at these, as Dr. Stewart was talking about, cytochrome P450 enzymes. And those are what break down drugs. And different drugs get broken down by different enzymes or groups of enzymes. And so the problem with some of these tests is they'll tell you, well, somebody's a rapid metabolizer at 2D6. And because of that, you shouldn't or should give them X or Y drug. The problem a little bit theoretically is enzymes don't work alone in isolation. So when somebody has an enzyme that's not working as well as it should, often other enzymes pick up the slack. And so it's kind of, again, I've been looking at these tests for years. Every bit of research that I've seen doesn't really show that somebody not using those tests does any worse with their patients. And so I think a lot of times these tests can tell people. What I worry about is when people say, I absolutely cannot be on Prozac. I had this test and it says, and it's just simply not true. And I think for me, what I always tell patients with these tests is they will be good someday. They'll be great someday. I think they're still in their infancy, and I think they can tell us some interesting stuff, but I think people are using them beyond what they're really able to be used for right now. And that doesn't mean they're not useful for some things, but I do think 10 years from now, 20 years from now, I think we all three of us hope that eventually we can just give somebody a test and it says Zoloft 217 milligrams, and that's you. We're just not there yet. And I think sometimes people think we are because of these tests, and they can be expensive. And so, again, I'd love to hear, Dr. Stewart's take, but for me right now, I kind of use the expression, they're not ready for prime time. I think they're an interesting tool and they're interesting in research, but how much they help a case clinically, with the research on that and what I've seen in my experience is it's just not there.
Yeah,
Go ahead.
if I can jump in as well. So for me, I've spent lots of years now, like way more than I'd want to admit publicly, studying OCD. And back in a previous phase, I spent a lot of time looking at genetics of OCD. So of course, it's interesting to me, and I think companies are making a lot of money looking at pharmacogenomic profiles. It's not that the results you get back are fake or non-scientific. I think it's very likelihood if you go with, a decent lab, that it is true. The question that comes in is, how much does that help you in terms of making a decision around medications? Similar to like way back with 23andMe and all of that kind of thing, people would want to get their whole genome checked out. And then companies were making a lot of money by saying, well, okay, so you can get this profile of yourself. If you're someone who likes to know about yourself, okay, then I don't think it hurts to get, pharmacogenomic profile. The question is, how confidently do you want to use that information to make a decision? So, and I'll just reflect that really a lot of the information today is looking at how the metabolism happens, but there has been, they also look at the serotonin transporter and whether you have a long and short arm or a long and long arm. And there's some evidence that may predict, depending on the form that you have, may predict a slightly better chance of improving for depression. But to my knowledge, there's no such evidence in OCD. So I would like to say, like beyond pharmacogenomics, I'd love to one day have a test where you get a sense of how much family accommodation is going on, how much avoidance you have, what is your sort of cognitive profile, also what's your pharmacogenomic profile. So if we're able to use all of that all together and then have some kind of algorithm or something to say, okay, here's a good starting place. For you, maybe it's better to start with a med, dampen things down, or maybe start with DBT, get emotion regulation stuff a bit better managed before you move into exposure response prevention. So I'm kind of open to what we have to learn, but we just need to be cautious to not overinterpret the value because it looks very scientific and you get, it looks like a fancy report that you get. And I'm not saying the report is wrong, but how you use the report, you need to do that cautiously. And certainly there's one of the companies, they use like a red light, yellow light, green light, without necessarily considering the whole story of the individual, because you're more than your genetic makeup, for sure. We all know this. And they probably overly simplify. And putting a red light on something, that might not mean that the medication would never work. It might mean you need to be cautious with the dosage, for example. So I think the information is only as valuable as the people who are holding the information and their ability to use their brains to think about it.
And I was just going to add to that. I think that's really important. I think both for me and Dr. Jared, I think a big part of what we think is important and our concern is we want the clinician to be able to use these tests and bring them into the overall case, and then you can use them. What we don't want is for clinicians to stop being clinicians and actually let the tests control them, right? And especially with young clinicians, who have grown up with these tests now, I don't want them just going, okay, here we go. And so I think, and I think the other scary thing for me, again, and this is in medicine in general, is this, and the patients getting the tests. And more often the patients read a test, they start thinking that they can interpret it. And they'll often scare themselves, or then they'll see the test and then I'll start them on a drug and they'll say, but the test says I can't be on that drug. And that's when it gets concerning. And so I think it's about how you use these things. And I think if you bring them into your larger picture, they're great. But I think when you start leaning on them as the answer, then I think that's when you can get into trouble.
It's really helpful, I'm sure, for everyone to hear this from you guys. Okay, so SSRIs are one thing. How about beyond SSRIs? What about, people are always asking me, the SSRIs haven't helped. What's the newest medicine on the scene? So beyond SSRIs, go.
I would say I don't think there's any other meds that you could use to replace SSRIs. I think the roles of other meds are added on SSRIs, and that's related to the mechanism of action. So really, we don't have other meds you can use instead they're clearly proven. There are a group of medications, Steve has already mentioned, called atypical antipsychotics, and you can use that in a low dose as opposed to the higher doses you use for SSRIs, but you can use low dose, add a little bit of an atypical antipsychotic onto the SSRI. You can also use a group of medication adding on called glutamatergic agents. That's not as commonly known. We don't have large double-blind placebo-controlled trials of these glutamatergic medications, but medications such as memantine might potentially be helpful as an add-on. Other medications may be helpful more in a Band-Aid short-term way, I would say. So benzodiazepines might help just dampen things down, although I'm really cautious. I think I used to use them much more regularly with people I was working with, but because of the ability to develop tolerance, I don't tend to use those as much as I used to as an add-on, but certainly they can be helpful if someone's in an acute period, waiting for the SSRIs to kick in. They can be valuable. Steve, what have I forgotten here?
No, I think it was good. Quick, so again, I think the most evidence we have outside of kind of the SSRIs is kind of using kind of atypical antipsychotics as an adjunct. And there are a couple of important things. One is the doses we use of those tend to be lower than you're going to see being used for bipolar disorder and schizophrenia. That said, I do think people use them a little bit too cavalierly a lot of the time. And I think sometimes they think, well, because we're using low doses, we don't have to worry. And there's not clear evidence that low doses can't cause tardive dyskinesia or that low doses can't cause metabolic issues. And so the thing that's really important to remember, because a lot of clinicians unfortunately don't, before anybody starts you on an atypical antipsychotic, the first thing they're supposed to do is get your cholesterol levels, your lipid levels, and your blood sugar levels, and your weight. And they get that before you start the drug, and they get that at the 3-month mark, and then usually every year after that. Because atypical antipsychotics can cause what's called metabolic syndrome, where people gain weight. They have what's called dyslipidemia. They can have increased cholesterol. It can cause insulin resistance or prediabetes. And I think, again, sometimes you see people not doing these tests, and I think because they think I'm using such a tiny dose that I don't have to, or they don't give people the appropriate warnings. And antipsychotics are great drugs, atypicals, and they do a lot of great things, but there are side effect profiles. And I think we have to be aware. My understanding of the data is about 1/3 of people who don't respond to an SSRI alone, about 1/3 of them will respond when you add a low dose atypical. It looks like we get even more of a response in people that have OCD and tic disorders, and people with that combination even respond a little bit better. But again, you have to be cautious with that. They're not something to be used cavalierly. And the only thing I would say is people also, again, I think there's a bias sometimes towards older medicine. And so while the atypicals work really well, low dose Haldol works very nicely when you add it, if you look at the research. And so, there are risks with Haldol, but there's also risks with atypicals. And so sometimes, we'll use very, very low dose of Haldol, which is a potent D2 blocker. And we know that can also kind of help in the augmentation. And the other thing I would say is I will use other agents. Depending on the case, there might be glutamatergic agents with less data, but that are safer. And so depending on the case, sometimes I'll say, look, depending on where we are, here's something that has a lot more evidence, but there are some downsides to it. And then here's something with a little bit less evidence, but if it works, often the side effect profiles are better. And that's a decision that you make with your patient on how you make kind of those decisions, because there's not a clear answer for that. You're weighing different risks and rewards.
I'm looking through questions to see what we've got. There's some pretty specific questions, but maybe you guys can help with that. So one person, so Matt B, 1214, which was now almost a half hour ago, said, I'm currently taking Zoloft, and one of the long-term side effects is I've got low libido. Is there any medication or supplements that can help reduce these side effects? So actually, maybe that gets to another question. What about medications? So sometimes, you'll hear, not just with OCD, but with any sort of medication, there'll be side effects, and I'm taking this to control that side effect. So how do you guys feel about another medication to control the side effects of the first medication?
I think the big picture answer to that is it's like weighing risks and benefits. So it depends on how much that side effect is interfering with life, and certainly sexual side effects. I mean, that can have a massive impact on someone's sense of self, the relationships, and even sense of shame, even though it's not your bad. It's a medication side effect that very often physicians don't even ask about. And it might be out of their own embarrassment or maybe not realizing so much. So I think number one, as prescribers, it's important for us to explain the potential side effects and to ask about these things, because people aren't necessarily going to volunteer it. And you notice I'm talking a lot, but I'm not jumping into some easy answer, because I wish there was an easy answer here. For this side effect around sexual side effects or low libido, so there's no quick, easy answer. There's different approaches that have been used. If you may have depression, so for individuals with OCD and depression, sometimes very often will use SSRI and a medication called bupropion. So one of the side effects of bupropion is it can sort of increase sexual, how do we say it? Minimize sexual side effects. So we know it helps with depression, and that can act in the other way. So what we know is when you're increasing serotonin, that causes sexual side effects. Increasing dopamine overall, it drives sexual activity. I remember way back someone said serotonin stops it and dopamine drives it in terms of, sex drive and sexual activities. So trying Wellbutrin is one approach that's used, added on potentially. Sometimes people will So for things like depression, they'll say switch to a non-serotonergic antidepressant. Well, we don't have the luxury in OCD because it's the serotonergic meds that are helpful, but unfortunately, it's the serotonergic effect that causes the side effects. Sometimes people will take a weekend holiday. So if they know there's a date night or something coming up, just not taking the meds for a couple of days to decrease the serum level. Of course, I don't like to overly encourage people missing doses, but that is an approach that's sometimes used. Yeah, it's tricky.
And that gets to a bigger picture thing that people often don't, I'm not sure everyone understands. Serotonin, like you mentioned, serotonin, dopamine, all of the neurotransmitters we're talking about, they do a lot of stuff in our bodies. They're not just about like mental health, right? Digestion, sexual functioning, muscle coordination. I mean, serotonin is like one of the biggest chemicals that we have, not one of the biggest, but one of the most enriched supply chemicals that we have in our body. It does so many different things. And so when you take a medicine like an SSRI, that doesn't just change serotonin in a way that's going to maybe change OCD. It changes serotonin all over your body and the way that serotonin is functioning and the way the serotonin system is functioning. And so you're going to get these kind of, for many people, wholesale, big, or kind of, well, I guess that's what side effects are.
Yeah. And I think that's I think it's an important thing to always point out that medicine, when you're using medicine in general, right? And some of them, it depends on their solubility and lipid solubility and how much gets into the brain. But in general, medicine goes where the blood goes. And the medicine's getting into your system and it goes everywhere. And we have a million different pathways. And so the SSRIs do things in pathways that are important, that are helpful, but they do a lot of different things. And I think in general, maybe just taking a step back to the SSRIs. So the drug in question was Zoloft, and Zoloft is an SSRI. And I want to be clear that the side effects are not specific to Zoloft. This is kind of all SSRIs. And probably the most common reasons that people will quit SSRIs due to side effects are sexual side effects. And probably the most common, even more than libido sexually, is what's called anorgasmia, where for both men and women, where the orgasm phase is either delayed or doesn't happen at all. And that's probably the most common sexual side effect. And then followed by kind of libido issues. The other thing is there can be weight gain with SSRIs. And it's usually not the weight gain at the degree that we see with atypical antipsychotics or some of the mood stabilizers. But there can be, legitimate weight gain issues. And then for some people, SSRIs are they just feel drugged and a little kind of tired on them. And so often those are some of the biggest side effects that we're dealing with and trying to find ways. And I agree completely with Dr. Stewart. I think Wellbutrin's one of the things, even when people don't have depression, and if they have libido issues, it's something I tried. It increases dopamine. But again, and then, outside of those, the other common SSRI side effects that you always want to ask about are people sweating at night, right? So some people with SSRIs will get a lot of sweating, and they'll wake up kind of drenched. Some people get some weird movements of what we call kind of myoclonic jerking sometimes in a muscle, and that gets really scary to them because they think about having a seizure. And so I think it's also just really important when you start an SSRI to let people know what the possible side effects are, and that the nice thing about SSRIs is pretty much all the side effects go away if we stop the medicine. And I think the other thing I always point out to patients is when you decide to do medicine, you're not giving up your right for the rest of your life to be off of medicine, and that when you're trying medicine, it's a trial. And it's something that we try. And if it doesn't work for you, or you don't like it, or just it's not worth it, we can always stop it. It's not surgery. And I sometimes feel like people think the decision is like whether I'm going to be on meds or not for life. And that's really not the case. These are things we try. If they work for you, great. If they don't, or if that's fine too. But it's not a life decision.
And if I can jump in, just so we don't scare people about side, like those commercials you see on TV, might cause this, that, the other thing, la la la, death. SSRIs, like the reason why I think people were keen when SSRIs came out is that they're very safe. They're very safe medications. And the other thing, in addition to feeling overly responsible, sometimes people with OCD can tend to have worries about their body or poisoning themselves or suspicions about what's there. They don't have total certainty ahead of time whether it's going to work or not work. So I really don't want people to leave this session being afraid of trying, just like ERP, you don't want to get scared away before you try things. And how we prescribe it is not jumping in the deep end. You start low dose and increase. And I work with a lot of families. And what I try and remind parents who might say, no, I don't want my kid on this kind of medication. But if their child had another disorder, they'd have no problem with their kid taking a proven medication for that illness. So this is a real illness. It's a real disease. And you need to look at it, not just be afraid of the side effects that might or might not happen in the future if you take meds. Let's look at the side effects of living with OCD. Oh, you're late for work. You're not getting to school. Maybe your social life is impaired. You're not able to play that sport that you like to, or the musical instrument. Your relationship is suffering with OCD. So there's a lot of side effects to living with OCD that people forget to take in. We're not going to prescribe if there's nothing wrong. Generally we're going to prescribe because OCD is causing significant impairment in your life. That's the thing we're trying to get rid of with the medication. So, because I could walk out of my door now, I could get run over by a car. All kinds of bad things can happen to me. Or even if I don't leave my house, bad things can happen here. And yet I want to do my best to move forward. John, I want to go buy you a light bulb for you.
My light here keeps going.
Yeah.
And I think
so I really don't want people to be looking for adding it on their list of reasons why they can't, because there can be scary things about any kind of therapy, especially ERP. That can be scary, but we're not saying don't try it. Yeah.
And even I think sometimes people will come in and they'll say, well, it's going to help my OCD, but they're worried it's going to damage what they look at as like their physical health. And one of the things I remind people of is we know that anxiety and stress are not good for your body, for any of the systems of your body. And so that living a life, I think like Dr. Stewart said, there are side effects of having the disease. And one of the side effects of having the disease is you pumping out cortisol and stress hormones. And that's not actually good for your long-term health. And so I think it's not only helping what people look at as their mind, but really their overall system. And I think remembering just because some people can get side effects doesn't mean you will. Most people tolerate SSRIs very well. If you throw a rock in any direction, you're going to hit somebody on one. And like Dr. Stewart said, part of the reason that we kind of use them so often is they're really safe. They can have some side effects. And if you get them, again, if we stop the medicine, the side effects go away. So it's not jumping like, oh, if I get this, it's never. And so there's no reason in a lot of cases not to do a trial. If you get a bunch, and then see, as opposed to making your decision before doing a trial.
Let's talk. Oh, go ahead. Go.
I was just hoping I could bang through some of the quick answers in the chat here.
Oh,
just
yeah,
for people who've been super patient.
Okay.
Let's see. Yeah, Matt B, increased dosing for Zoloft helped me a lot. So again, that goes back to what Steve said. You can sit on a low dose of a med for a long time. If it's not, I want to max out what a med is able to do, figure it out, and then move on if it's not great. There's one about adding clonazepam. So that's in that group called benzodiazepines that I've been talking about. So that can be helpful. Typically short term. If someone's requiring more and more clonazepam, then I tend to try and minimize that. And that also gets in the way of exposure and response prevention. There's something about
I'm going to ask you guys about that, but go ahead, keep going.
Yeah, also dose of escitalopram, we go to around 20. Ketamine, not good evidence for ketamine and OCD. In depression, there's some. So with OCD, I think there's maybe one trial, but maybe the feel-good impact was fairly short-lived. Although I can't say for certainty. I haven't read that. I haven't read about it recently. Any other quick ones here?
I see somebody asking about agitation and most SSRIs. And again, SSRIs can do either. They can kind of make somebody tired and a little sleepy, and some people they can make a little agitated and give insomnia too. Often, a lot of that is, again, making sure that you've tried different SSRIs are more likely some to be sedating and agitating, and then learning how to kind of use dosages. And sometimes when people do have agitation to all of the SSRIs, we might have to add something on. But often, I think if somebody really knows, you can often find an SSRI that fits somebody's particular kind of profile. But agitation is something that can happen. It's not hugely common, but it can happen to some people. And when people do get agitated, you also just always want to make sure diagnostically that you're sure what's going on, right? And that you're not giving, because again, people with the OCD could also have other disorders. And so you also want to always be careful and make sure you know what all your diagnoses are.
Yeah, and I might try and decrease the dose with agitation. I see Austin Swales this is the thing we published on in the last year. They've been taking fluvoxamine for 4 weeks. Doctor wants to add on some clomipramine. Is that common? I'm hoping it becomes increasingly common because by starting clomipramine when you have fluvoxamine in your system, we can get away with using way smaller doses. Typically, when I used to use clomipramine on its own, it'd be like, 225 milligrams was common. In the last decade, I've not prescribed more than 50 milligrams. So it minimizes the side effects of clomipramine by starting it when you're already taking fluvoxamine. That being said, if you've only been trying the fluvoxamine for 4 weeks, give it a chance. See if it on its own can help. And, are you taking a dose like around, 200? Anyway, are you up to 200, 250, 300? So give that a chance because, again, one med rather than two. But if 2 meds helps make it more tolerable, then that's sometimes the.
And I think we should just say it really quickly because we see it all the time. Sometimes people that are just on clomipramine, they get on a certain dose and it doesn't work and they stop it. And people don't get levels. And I think, sometimes what you see is people who are on a lot of clomipramine, when you look at their drug levels, end up having a very low level of clomipramine and a very high level of desmethylclomipramine. And so, and sometimes that's originally, I think Dr. Stewart talked about her most recent strategy, which is really great, where you can use low dose clomipramine. But even when people were using regular kind of doses of clomipramine, a lot of times people wouldn't get a response. And we would add a low dose of Luvox, even 25 milligrams or so. And what you would see sometimes is that now the clomipramine level goes up, the desmethylclomipramine level goes down, and people start to respond. So I think anybody, if you're using clomipramine and it's not working, before you give up, I think you always want to check the levels and see how much clomipramine the person really is getting in their system, because often they're not.
Yeah, totally. And again, just so that this is said, because it's important to know, you need it. If you're taking clomipramine, you need to get an ECG done and you need to get levels done. And again, why we you start with fluvoxamine and add a bit of clomipramine, means you're not going to overshoot. If you're already on a certain dose of clomipramine and add Luvox, it could make the level shoot up more. So again, yeah.
Well, you both are just fountains of information. This is fantastic. If Kyle had to miss one of these live streams and me kind of be in charge, this was the one to do it, because I really, you guys just ran the show, which is fantastic. A wealth of information. I know this is really helpful for folks, but we are at the end of the hour. And so in closing, let me say, first of all, thank you to the two of you. I hope I get to see you in person sometime soon. And to folks out there tuning in, this live stream is one of many. We've got some really cool ones being planned for the upcoming months through the spring. And you can see the entire schedule of future streams if you go to iocdf.org/peace of mind. You can also view recordings of this and other past live streams, as well as watch our hosts answer your pre-submitted questions in the OCD mailbag on IOCDF's YouTube channel, which is youtube.com/IOCDF. So remember to like and subscribe and get notified when live streams are scheduled. And of course, if you need resources, please visit IOCDF. Thank you again, Steve and Evelyn. This was really cool. I know that we provided a lot of great information for folks, and it's great to see you guys. So yeah, thanks again. And thanks, Amanda, for organizing and producing this.
Thank you guys for all the great work you do.
Thanks so much for having us.
All right. Bye, everyone.